Starting Point Coaching and Consulting presents Kairos Conversations, Connecting with Quality, the podcast. Kairos is Greek for the right time, the right season, the right opportunity. This podcast features healthcare quality professionals who share their journeys, their advice, their struggles, how they made that transition into a new and exciting role. My heart's desire is that you find this podcast to be inspirational to you as you make your own journey. Don't forget to share this podcast with your colleagues and friends and rate us on whichever podcast platform you listen to. Thank you for being here. Thank you so much for tuning in today. Today, I am joined by my next guest, Joe Harrision. Thank you so much for being here, Joe.
Oh, it's my pleasure, Brandy. Thanks for having me.
Let's start by introducing yourself to the audience.
Okay. My name is Joseph Harrision. I'm trained as a family nurse practitioner, but spent the bulk of my 12-year career specializing in adult and geriatric behavioral health. Have worked in a number of different settings and different roles in that capacity, and have grown a lot in that time. I'm currently the founder and CEO of a new company called Avail Health.
I am so excited about your journey because it was such a non-traditional path. I'd love for you to share, if you're open to it, how it got started, because you used to work in retail, restaurant type industry, right?
That's correct. Yeah. I'm happy to share something about that. So I was not a traditionally good student. Was always, bright according to my teachers, very, very social, and had trouble focusing. And then I would say a series of adverse events in my middle childhood kind of set me up to not do so well academically. And by the time I was approaching high school completion age, I was having to actually look for alternatives to graduate because I hadn't met my credit requirements. And so I, didn't go straight to college. It was not on my mind. Many of my classmates did. I was very privileged in my childhood going to excellent public schools, but just didn't have that sort of focus. My family or family of immigrants, they're, working class parents that didn't have access to university, didn't have that expectation of me, went into the restaurant industry, did some work in the construction industry, and did a lot of traveling. And the restaurant industry, first as a waiter and then a bartender and a manager, enabled me to work in multiple countries, really explore. I don't regret that time period, but I realized by the time I was in my early 20s, I needed to think about my future a little more seriously. Had multiple friends graduating from college and moving into career jobs, and really didn't yet even have a direction for myself.
So how did you switch from that place where you were to thinking about nursing and healthcare at all?
I didn't even go straight from there to nursing. What I did is I started going to community college in the city of Oakland, California. And as I said, I'd been quite well prepared in public school, just hadn't applied myself. So I realized very quickly the disparities in educational preparation. And I was actually at that college at the time when the Welfare to Work program was underway, and a lot of single moms were being forced off of income support into the work world while caring for multiple children. I just happened to join a tutoring job at that time and was doing a lot of tutoring and support for these women that were essentially, taking care of their families and also in school full time and often also working. And it really opened my eyes. So I became quite politicized during that time, and I started being a student activist. I transferred to Cal Berkeley, where I worked on issues like sweatshop actions against universities who were buying their clothes from unsafe facilities around the world. And I got into anti-war activism. I was a student during the 9/11 attacks. And so a lot was going on at that time. And I started a nonprofit organization doing development work in Central America. because while I was studying in my program at Cal, I had a language requirement. And so the language requirement didn't push me, but gave me the opportunity to travel to Guatemala, to the highlands, that in a place that a 30-year sort of ethnic cleansing war of the state against the indigenous people had just ended. And I saw absolute poverty for the first time. And it really made me realize I wanted to do more in the world. So I started a nonprofit. And while I was doing that, I started substitute teaching. Sorry, this is a very circuitous route. I started substitute teaching and in East Oakland. And I was recruited very heavily by principals there to come on as a full-time teacher. So I entered one of these, train while you teach programs where you do this intensive summer preparation and then work full time as a teacher. So I did that and worked in East Oakland for 4 years as a teacher, and then transferred to an adjacent district. But I burned out really hard as a teacher. And so the way I found myself in nursing was I did not want to stop being in the helping professions, but I felt that I couldn't continue as a teacher. It wasn't a great fit for me. Some of the primary activities of teaching I found really monotonous and tiresome. And then also I'd chosen to teach in in an environment where the children were quite traumatized, and I had a lot of vicarious trauma in the role. So I went back to the drawing board. And when I started looking at helping professions, I found nursing, and then very quickly afterwards found nurse practitioning.
So it's interesting because there's so many overlaps between the burnout that's happening with teachers and the burnout that's happening in healthcare. But with some of the disparities that you saw, through your travels and when you were a teacher, do you see that carry over into the healthcare space as well?
Absolutely. And for me, I think what I was lucky because I don't want to say lucky, but because I had experienced burnout and I had this very personal relationship with it. When I chose, I should mention when I left teaching, I actually spent about 1.5 years doing prerequisites to go to nursing school because my college education was quite some time before that. And so, I had to repeat some courses and then do some science courses that I hadn't done in my undergraduate. And that pushed me back into the hospitality business to make a living. And so I was working in hospitality and preparing for teaching. And I had time to, psychologically, I made some promises to myself that I would take better care of myself and that I would find a way to sustain this career without burning out. And that I will say that I have done that, but it has not been, it has required a great deal of me to not burn out again in my new, more recent career.
How do you do that? Because I have a lot of listeners who are at that stage, right? They're working in healthcare, they're burning out, they are seeing things that they didn't think they'd see. They just want to take care of patients, but there's so many things that are getting in the way of that. How do you prevent the burnout, knowing that you've experienced it before?
Yeah, that's the million, or is it $1 trillion question? I mean, it's, I think I'll just speak for myself. I'm a, middle class, well-educated, quite privileged, white, cis, hetero male, who's married with a couple of young children. And I had certain, protective factors that have helped me. So it's not all my own choices, and not everybody is facing burnout with the same resources and support. I also happened to fall into a field where I was really quite rarefied in terms of my specialty and skills as a psychiatric specialist in the Medicare space. That I had certain job protections that not everybody experiences. That I was in a position. Essentially, what I did, Brandy, is I renegotiated my role a couple of times. I went to my boss. I did it very professionally. I was really on the edge, actually, the first time I did this. And I went to my boss and I said, listen, here's what my plan is for surviving this job. And I really made it very clear that if he didn't want to work with me, I was going to have to figure something else out. And I was able to do that, I believe, because I could have very easily found another job. And I already had recruiters, reaching out to me regularly. But they were also offering jobs that felt impossible, So I fortunately had a very enlightened boss who saw that he saw that I was a serious person. I was a professional. I was very committed to my patients and my team, and that I just was really, having a hard time. And so he helped me and enabled me to reduce my hours. I had to take a pay cut, of course, but it did give me a breather. And then I want to give a shout out, actually. So that was Dr. Ali Khan. I'll just name him. He's a really a wonderful person. He's recently risen to become the chief medical officer of Aetna Medicare. He really deserves that because he's a very humanistic leader. And another thing that helped me was actually good leadership in my organization. I had the former CEO of CareMore, where I worked. I wrote sort of a white paper saying, listen, I cannot do this without more resources. I care about these patients. There's so many social determinants of health here. There's so much sort of deferred care of these 65-year-olds coming onto a low cost Medicare Advantage health plan. And we need more team. We need more social work support. We need more psychotherapy support. I need a dedicated MA on my schedule. I felt there was a strange structure where the psych providers didn't have dedicated MAs, even though I was probably the busiest prescriber in the entire clinic. And so those things got fixed. So that helped me. And then the third thing, and this is all really advocacy related, was that a new leader came into the behavioral health department at the company and did this sort of, national tour and actually asked us what was broken and what needed to be fixed. And then one of them was the schedule structure. And so she managed within about 6 months, Dr. Jenny Byrne, who's recently published a book I highly recommend.
I've met her.
Oh yeah, she's a phenomenal leader and a humanist. And she's all about making things better. And so she did make things better. So she really rescued me the second time I almost burned out as a provider by finally implementing like a clinical schedule that was rational. And so I went from having 21 slots on my schedule every day and only 40 minutes for a new intake from patients who averaged over 70 years old to I think it was a total of 13 slots on my schedule every day of 30 minutes and 60 minutes for new patients. It was game changing for me, and it helped me persist.
That's interesting because a lot of employers will say, oh, we need you to be productive because of this reason, or we need you to be productive so that, we can be financially viable. How did that work in your case, or were you even privy to that?
There was a bit above, the analysis was not, I wasn't privy to the economic analysis that led to that change. But I will say that, healthcare systems have to balance the quote unquote economic productivity of their staff with the cost of losing staff and having to rehire and retrain staff. And in particular, finding skillful, dedicated psychiatric and professionals and psychotherapists to work in the Medicare space, I think is really, really challenging. So it may have been because, it wasn't like a global change in schedule for everyone. It was, about 50 clinicians around the country that got that change in their schedule. So yes, you're right. That analysis as a CEO, I have to do that now, right? I have to think about unit economics. I have to think about gross margin, because there's only so much we get paid for care by the payers. In this particular case, it was a Medicare Advantage health plan. And so it has, a payment structure that's called a capitated payment structure, which means that based on the risk of poor health outcomes a person is experiencing, which is tied to their chronic diagnoses, that person's the CMS will pay the Medicare Advantage health plan based on their risk. And then what the health plan does is it aggregates all the patients that it's taking care of, all the revenue from those patients from CMS and all of the premiums from the patients. And then it it dedicates more funding on the front side to prevent hospitalizations, more funding on. So there's this sort of like hypothetical alignment of the patient's interest of being more well and the business interest of success, right? So the better care you take of patients, the less they end up costing because of they utilize inpatient resources less. And that leads to you creating what's called an MLR, the medical loss ratio, which is essentially your profit margin as a Medicare Advantage health plan. And so you can make an economic argument in that type of structure, not in a fee-for-service structure, right? If you go from 21 visits to 13 in a fee-for-service structure, your revenue drops way down. The fee-for-service structure, the entity that's doing that isn't getting any reward for taking better care of the patient, which is why we're trying to do away with just simple fee-for-service structures. So in the model I was in, taking better care of your providers and giving them more time to spend with patients would produce better outcomes for those patients, which essentially, even though they're quote unquote less productive, they're actually more productive because patients do better hypothetically and are less likely to be hospitalized.
I absolutely love that. Let's get that on board today. And I know I've talked to some people about value-based care and where that's headed. And it sounds like a lot of what you're saying is that value-based care.
That's right.
The biggest mistake I see clinicians make when transitioning away from direct patient care is applying for every available role. Problem is, it's like throwing darts at a board, hoping something sticks. And let's be real, employers can sniff this out like a canine, and it makes the candidate come off as unfocused. The solution, my friend? Do some deep introspective work to identify your passions, skills, and strengths, and find roles that align with that. That's why I've partnered with Career Clinic, who created the healthcare career profile that I wish I had created first. It's called Stream Ahead, and it takes about 10 minutes to complete. It is time well spent to get detailed report of the top work streams that fit who you are. I'll link the assessment in the show notes section of this podcast. And you can use the code BRANDY10, that's BRANDY10 for 10% off. Now let's get back to today's episode.
The value-based care model is, came out of, I don't want to say came out of, but it was first materialized in the Medicare Advantage health law of, I think it was 1996. Where it created this alignment between the payer's interest and the patient's interest. Now, there's been a lot of development and a lot of trial and error since then. And there's still some people who don't think value-based care is realizing its aim or its mission. In my experience working in that space, it gave me tools and networks of skilled professionals that I could bring to bear on behalf of my patients' needs. That is almost impossible to find in most settings. And I was working at not just a value-based care company. I was working at a highly innovative value-based care company that has gone on to inspire many new companies, including my own. So not all are alike, but yes, I believe it is a much stronger funding mechanism for care delivery, particularly for patients with high needs, because you have a much more likely chance of realizing the quadruple aim of healthcare, where, patients' experiences are better, providers' experiences are better, the outcomes at the population health are better, the cost of care is reduced, and you're getting closer to realizing health equity, which is one of my, that's why I actually, by the way, I use the quintuple aim of healthcare, rather than the quadruple aim, because we have to put that health equity piece as a core feature of any models we're designing.
How do we put that into practice on a day-to-day perspective? Because when people talk about health equity, which I agree with you, and when people talk about health equity, it seems so big and so daunting. Like, how do I know I want to make change. I know I see this disparity, that disparities exist, but I don't even know where to start. So how would you suggest people take practical steps towards that quintuple aim?
I love that question, Brandy. This is on my mind right now because we're building out an academy inside my new company. And so, this is sort of my vision, right? So I'm working with my founding team, and I just loaded a bunch of outlines of trainings into our workspace, asking them to look at them and give me feedback. And so my answer to that, like my first answer, is we have to be educated. We, first of all, privilege blinds. So coming from my background, if I hadn't spent the last 30 years unlearning racism, unlearning classism, unlearning sexism, homophobia, like I would not be the clinician I am. And I'm not done, right? Like that's a lifelong journey. That's not you don't graduate from that university. But I really like the term Dr. Uche Blackstock's recent book, Legacy, I've been reading as a part of my continuing commitment to growth. And she uses the term structural competency.
Mm-hmm.
And I really like that term because what it's getting at is, there's terms that if you're, I'm sorry, I don't know if everybody's familiar with these terms, but the difference between, direct racism, for example, and structural racism, where direct racism is like an interpersonal experience where one person, either consciously or unconsciously does something that causes harm to another person related to race and their beliefs, their ideology, their assumptions, whatever it may be. Everything from very explicit aggressive behavior to what are termed microaggressions, that's a form of racism. But there's another form which is like based on institutions, like public policy, regulations, past laws, even business policies that can completely change the life course of a person and has been in our society for the whole length of our society. And so understanding some of those things, it can give a clinician great insight into the life of the person that's in front of them. And when we talk about social determinants of health, we're talking in part about those structural inequalities or structural inequities that exist in society and how some people have actually a much harder path than others. And that affects their health every single day. It affects their longevity. It affects the number and severity of their chronic conditions. It certainly affects their mental and behavioral health. And so understanding some of that gives you new eyes to and new ears to see and hear your patients. And as a practice, I would say we still don't want to make assumptions, right? Because just because someone's in front of you looks a certain way doesn't mean that they have exactly the same experience as everyone that looks like them. But it's just like we think about, an older adult white male having certain risk factors. We want to approach a clinical visit with that patient, like with those things in mind. We can do the same thing for a person, for a 65-year-old new Medicare recipient African-American woman, that understanding something about the structure of society, about public policy, about the legacy of redlining, for example, the legacy of de facto and de jure segregation, the legacy of how affluence or how financial assets are passed down from family to family, and how certain people of certain backgrounds have not actually had the privilege of passing assets down because of the history of this country. It makes a total difference in the quality of care.
100%. I mean, you just said that. So you put that into words for a lot of people that feel like privilege doesn't really exist. Like it's a faction of somebody's mind, but it does exist, and it does impact health. It does impact people's experiences in the world and in healthcare and in how, their longevity of life.
It does. And I think I just want to address, because I've named my race and gender here. I just want to address something to other white folks and white men who may be confronting the gaps in their knowledge or understanding, that I see very often, and I have seen over decades now, a sort of knee-jerk defensiveness around the concept of racial inequality or inequity. And I often reflect on that, as I think many people do who are frustrated with the lack of progress. And I do think that there's this simple dichotomous thinking that people think if we say that a first generation American from Mexico whose parents were migrant farm workers and who went to a very, very inadequately funded, public education system and came up and managed to, just through their sheer, resilience and fortitude and aspiration, became a professional, that somehow if we say that professional has the same, chance in success in life, if that they don't have the same chance of success at life, that somehow we're negating the lived experience of a white man who may have had their own adversity, their own challenge. And so there's this rejection of this idea of social inequality or inequity because it feels like it's dismissing or negating other human beings' journey. And what I just advise my, white folks who may have that reaction is to recognize that those two things don't have to coexist. Those two things can coexist very comfortably. You can have had your challenges, you could have had your obstacles, you could have had your own suffering, and that isn't negated by the recognition that there's yet even more obstacles or challenges that some people face because of our society's history and present, policies.
All right. Tell me the name of the book again, because I want to link it in the show notes for people to check out the book that you mentioned, Legacy.
Yes, Legacy. I don't remember the subtitle. And for those who are as busy as I am, I actually have been listening on the audiobook version. And it's called Legacy, A Black Physician Reckons with Racism in Medicine.
All right. I will link that for people in the show notes.
Yeah, Dr. Blackstock she's formed an organization that actually trains and works with healthcare organizations to mitigate this, to try to work through this and help clinicians and clinical teams to just really try to make sure that they're not actually perpetuating these inequalities in their own practices. And so I think that's really powerful, an opportunity for any leaders in a healthcare space you don't have to know all of this on your own, right? There are resources out there. There are people dedicating their careers to helping us to overcome these issues.
Awesome. All right. So let's talk about what you're doing now, because you said you work for Avail.
Yeah, I'm the founder and CEO of Avail Health. It's a new company. It's what we call a healthcare startup. And I come, as I mentioned, I'm a nurse practitioner. I identify very strongly with nursing, with the history of nursing and with the power of nursing. And I just really feel that, there's a crisis in nursing, as you know. There's a crisis of burnout. There's a crisis of people are experiencing sort of existential challenges around whether they made the right choice in their career, what to do next. A lot of nurses feel trapped. And there's because nurses don't have what's called they don't have in their credentialing, they are not able to bill encounter codes in the outpatient setting. They're not able to just sign off a note and submit a code and be paid for it. At increasing rates, there are codes that nurses can deliver in the outpatient setting that have to be billed under another provider's license, like a nurse practitioner, a physician, or PA. But because, circling back to the value-based care conversation, there is now there is a way now to actually leverage the great genius of nurses in the outpatient setting to the betterment of patients' lives, to society, to realizing the quintuple aim of healthcare. I'm basically building a company that is going to move thousands and thousands of nurses into the outpatient setting, taking care of persons with chronic illness, and enabling a lot of people to not have those hospitalizations, and enabling nurses an alternative career path where they can do something deeply meaningful, really powerful in the lives of people, and also make a good living doing it. And in a lot of places in this country, nurses aren't even making a good living while they're carrying the weight of the world on their shoulders. And that does not have to be that way. I'm really committed to try to reduce the need for hospitals in our society by taking better care of folks. And I believe that the linchpin for doing this, for rescuing primary care, is empowering nurses. So that's what my company is doing.
And so in this primary care model, how would patients come into this model?
So it's going to vary depending on, we have different clinical products. So I think a really straightforward product that people can understand is a product that we're calling transitions of care. And that's a
Mm-hmm.
term that a lot of healthcare professionals know. But so in this particular product, we would contract with hospital or a Medicare Advantage health plan or an accountable care organization, any type of organization that is at risk for having to pay for the cost of care of a patient, that we will send a nurse into the hospital from outside when the patient is in the hospital. The nurse will meet and get to know the patient and their needs. Will kind of capture the picture of the patient. And then when the patient is discharged from the hospital, the nurse will see that patient in the community within 3 days of discharge. And this particular model will reduce the readmission rate of patients by up to 30%, which is, we're talking about billions and billions of dollars, hundreds of billions actually at the national level, that can be prevented. So that's one example of sort of a short-term relationship between a nurse and a patient. Another more kind of comprehensive longitudinal relationship is we have a product called comprehensive behavioral health, and that's where a Medicare patient is followed by their PCP, and then one of our psychiatric specialists and also or a psychotherapist, a licensed clinical social worker, will take on that patient on their panel and follow them as a virtual provider. And what will be in between the PCP and the psychiatric or psychotherapist and the patient will be a mobile registered nurse and community health worker. And that nurse will essentially become the de facto primary care provider for that patient, coordinating all their care, making sure the PCP's voice is there. A lot of these patients are not seen often or at all by their PCPs because they have mobility challenges, social determinants of health interfering with their ability to be seen. And we basically bridge that gap. We close that gap. We get them the specialty care they need, and we get them the social determinants of health support that they need. And, nurses are the most trusted profession in America for many, many years. They have a powerful ability to establish really trusting relationships with people. And this model basically puts the nurse in the quarterback role and allows PCPs to get the help they need with their most complex and disengaged patients, and enables a virtual model of psychiatry and psychotherapy to be realistic for disengaged patients who might not otherwise come on to the visit.
Yeah. And I think as the model expands, and I was talking to someone on a podcast episode recently about it as well. But as this model is expanding, there's going to be a lot of space for the therapists, for the physical occupational therapists to come in and be a part of the primary care model, so that the patient is getting everything they need without having that return to the hospital, like you said, or being able to collaborate with the nursing side to get the patient the totality of what they need, kind of all in one space, all in one setting.
I agree completely. In fact, the focus is on registered nurses, but it is actually truly an interprofessional, collaborative, team-based care model. And the ultimate realization of that comprehensive behavioral health model I just mentioned, or its sister model, which is actually more a global comprehensive program that covers medical needs as well, is a combination of like virtual speech and language pathology, virtual mobile occupational therapy, mobile physical therapy, and the same kind of contracting structures that I'm able to use with at-risk entities that are responsible for the full cost of care. They don't just work for nurses, they work for physical therapists as well. They work for occupational therapists as well. And as we develop the model, like you said, we can have this sort of fully realized comprehensive model that manages risk in the outpatient setting in a way that lets people live where they want to live and stay where they want to live, and saves the system a fortune and improves the experience of all the providers and the patients.
Yeah, and I'm so excited to see where this goes, because I think this is definitely what our healthcare system needs to really move forward and to be sustainable in the long term, and to really help patients like we want to help patients. How can people connect with you, Joe?
I'm on LinkedIn. I'd love to have more connections. My company website is availhealthcare.co. And I welcome emails at that, Joe, at that at that URL, availhealthcare.co. Really appreciate your time and interest, Brandy, and love what you're doing with this podcast.
Awesome. Thank you so much for being here.
My pleasure.
Thank you so much for listening to the show. It would mean a lot if you would share this episode with a friend or a colleague. I would be honored to encourage them in their journey too.